It is evident that the majority of the above-mentioned population do not afford proper medical professional care, besides living in conditions of abject poverty, surrounded by high rate of asthma risk-associated factors.
Main hospital in Tanzania don't have asthma treatment at all.
The cost of the drugs is also very high. And then diagnosis machines. We don't have enough diagnosis machines also to assess all those who have, or to diagnose all those who have suffering from diseases like this.
Nigeria currently has limited available asthma medicines. The few available asthma medicines are the ones that are not recommended for a longer period due to their established multiple adverse effects on the users. The only few available ICS containing medicines are originator products, which are very, very expensive, hence unaffordable to most asthma patients in Nigeria. Out-of-pocket expenditure constituting over 77% of the total health expenditure as at the last available data. The implication of this access issue is what we have witnessed, where most asthma patients go through burden of asthma symptoms, limited activities that has led to mobility. And in most cases, we have also seen a lot of deaths, which are occasioned by the lack of access to asthma medicine.
The one availability of knowledge and awareness of that among the patients as well as healthcare providers. That is the prime one. Then inequality in accessing as well as diagnosing asthma among patients of all strata.
Among India's 1.31 billion people, about 6% of children and 2% of adults have asthma. Most of the people do not have health insurance, and there is a wide gap in healthcare facilities for rich and poor. Almost all types of inhaled steroids, inhalers are available at pharmacies, but these are expensive in comparison to oral formulations. In low middle income countries, the proportion of people with non-allergic asthma is greater than in high income countries.
So we have to educate the patients as well as the patient's family as well as the healthcare providers. Many may not know the asthma triggers. Even though it is genetic, sometimes it is non-genetics involving indoor pollution related with chemicals or biological exposure like dust, mites, etc. Many refuse to take inhaler therapy because they think that they relate it with smoking and they may cause addiction in their life. So many patients refuse to take inhalers in our community here.
Most patients don't have control medication for asthma because they are too expensive. So patients have most exacerbation because they are not controlled. And one other problem is that we have many streets that are not paved. So that means that there is more dust, which cause exacerbation.
The trash management here happens by burning the trash, and so we in our clinic see a huge surge of patients who come in with asthma exacerbations on days when there's trash burning going on in neighborhoods. Also, a lot of our families live in houses where there is where water leaks in when it rains and where there's a lot of mold, and that is another thing that causes a lot of exacerbation. So there's a need to look at providing medications affordably and also the upstream factors in terms of environmental health.
Se tendría que crear una conexión por medio de la educación para que se manejen los mismos conceptos sobre la enfermedad.